A very good evening to all of you. I and Dr. Arpan Gandhi, we would be together presenting a case of endophthalmitis. So can the AV team help me to move my slides, please? So Dr. Arpan is heading the lab services at our hospital, Dr. Shroff's Chartier Hospital in New Delhi.
पहले उनकी
Thanks. So I'm presenting the case of a 40-year-old male patient who presented with sudden painful diminution of vision and redness in the right eye for last 1 month. He had a history of uneventful phacoemulsification surgery with IOL implantation 2 months back, and he had been diagnosed with endophthalmitis elsewhere, same institute where he got operated, and treated with 1 intravitreal injection of a combination of antibiotics. The details were really not known. So this is how the eye looked. The vision was 624 N36. It was a highly inflamed eye with an element of corneal edema, a lot of fibrinous reaction over the IOL with hypopyon, AC cells and flare. And as far as the fundus is concerned, there was an extensive vitreous haze. However, second order retinal vessels were visible. So we took an AC sample and it was sent for the microbiological examination, both for bacteria and fungus. An intravitreal injection of vancomycin and deca was given, and the patient was started on oral antibiotics and oral steroids. And the patient started resolving, and he started showing a response to the treatment, which was provided as a first-line management without any microbiological backup. And there was a gradual improvement in the condition of the patient. So 1 month later, again, the patient presented with diminution of vision and a circumcorneal congestion, streak hypopyon, fibrin over the IOL, and the vitreous showed exudates with no fundus details seen. And the AC tab that we had sent earlier came out to be all negative, and there was absolutely no growth. So we didn't know what organism we were dealing with. So this time we were a little more aggressive, and we went ahead and did an IOL removal with core vitrectomy, and intravitreal injection again of the same antibiotics was repeated because the patient had shown a good response the first time that the patient had presented to us. And this time we sent the sample of the vitreous and the IOL sample again for the microbiological examination. Post-operatively, the patient looked quite good. There was a good red glow, and the AC looked pretty quiet. There was a mild circumcorneal congestion which was expected after the surgery. And the patient, of course, was aphakic because we had removed the IOL. The sample of the vitreous that was sent to our lab on KOH examination showed septate curved fusiform macroconidias, which are classically described as banana-shaped colonies, and it came out to be Fusarium species to our surprise. So the patient was on topical and oral steroids, which were stopped after the microbiome report came in, and the patient was started on oral antifungals as well as topical antifungals, and the steroids in all forms were stopped. Intravitreal voriconazole was repeated every 24 hours for 3 days and then every alternate day. On culture also, there were the growth of these fluffy white colonies on blood agar and Sebrot's dextrose agar, which were suggestive of Fusarium solenis species, and I'm sure Dr. Arpan will add more knowledge to us. And 2 weeks post-operatively, there was a recurrence again of exudates in the vitreous cavity, and a revitrectomy this time again was done, and an intravitreal voriconazole was given with post-op voriconazole injections. 5 months, the patient was absolutely good. The media had cleared up. The BCV in the right eye had improved to 20/60 and 18. But 6 months later, the patient came back again with a drop of vision to hand movements, with gross lid edema, chemosis, congestion, AC reaction, hypopyon. And this time we could see a ball of fungus right behind the iris, which is the predisposed site for any fungus to grow because it is a cool area and it's a dark area behind the iris. And this is on a more magnified view where you can beautifully appreciate the fungal ball behind the iris. So we knew that the vitrectomy, IOL removal had all gone waste and the patient was still having a persistent fungal infection behind the iris. So we decided to do a transscleral cryotherapy, a double freeze thaw to the fungal ball, and oral, topical and intravitreal voriconazoles were again restarted for this patient. And this is just a short video. This is something which we do when we see these fungal balls behind the iris, because we know that this is already a vitrectomized eye. And this basically helps to destroy the fungal cells. So this is the cryo probe. And on depression, you can actually approach the fungal ball area behind the iris. And with the double freeze thaw, you can actually damage the fungal cells. So the eye was quiet with a low digital pressure. And therefore, we had to resort to a revitrectomy with silicone oil injection. And on regular follow-up, now the eye was quiet. The patient had recovered a vision of 636 N36. The pressures were good. They were 80 millimeters of mercury. The eye was quiet, and you see a good fundus, well-attached retina with silicone oil in situ with some amount of ERM formation. So post-op endophthalmitis is very much a true ocular emergency, as we all know, and it's a potential complication of any intraocular surgery. We should be knowing how to differentiate between infection and inflammation. And the clinical diagnosis, of course, has very typical symptoms and signs. But what we need to understand is when we are dealing with a fungal endophthalmitis, the symptoms can be very less in comparison to the number of signs that we are having. And we also have to look for a risk factor for the development of endophthalmitis. And I'll just request Dr. Arpan now to just add a few words of wisdom on the micro